So good afternoon, everybody, and welcome to this EDS UK webinar with Nicci Rogers. And Nicci, thank you so much for agreeing to run us this webinar on foot and ankle joint strain, instability, and plantar fasciitis. Is that the right word?
Plantar fasciitis, yeah.
It's what?
Plantar fasciitis.
Thank you. And Nicci's an experienced orthotist with EDS herself, and she's the regional clinical and operational lead for Opcare. So thank you so much, Nicci, for giving your time to us today. So I will pass over to you. Thank you.
Thank you. So I'm just going to share my screen. So let me know if everyone can see this. Perfect. So as Nicci said, I'm also Nicci. So just a little bit of background on myself. So I have EDS, but my career trajectory was quite different what I'd initially planned it to be. So I'd always essentially worked in care. And then 18 years ago, when I was 21, I got diagnosed with EDS. And at that point, that really sort of changed my life for me. So I was very similar to most of you on that merry-go-round of trying to get answers and essentially having all these symptoms and trying to figure out what was going on with me. When I eventually did get my diagnosis 18 years ago, that's when everything really changed for me, essentially. So I quite quickly realized that everyone with EDS is going to see an orthotist at some point in their life. I quite quickly realized that there was such a lack of knowledge in EDS, particularly within that area, same as there still is in certain areas and certain departments in different professions that they are still going on today. So what I did is I actually changed my career trajectory completely. I took myself back to university and I qualified as an orthotist and prosthetist. So what you'll find as we go through this presentation is that everyone who is an orthotist is dual qualified. We all do prosthetics as well. So that makes our prescriptions quite unique compared to other departments and other specialities because we're looking at you from head to toe. So what we're going to look at today is we're going to have a look at understanding the role between orthotists and podiatrists. So the reason that I popped that in is because we're going to be talking about insoles and we're going to be talking about foot and ankle conditions. Everyone always gets us confused with what we essentially can do and then what a podiatrist can do. So I thought it was really important just to be able to distinguish both of us. We're then going to explore the foot biomechanics and proprioception, and then we're going to examine joint hypermobility and analyze common foot conditions that you tend to see with a hypermobile foot. And then essentially the importance of appropriate footwear. So essentially orthotists and podiatry. So orthotists are dual qualified. We do orthotics and prosthetics. We have quite a heavy degree in terms of looking at gait analysis. So with orthotists, what makes us slightly different to other professions is we make devices and prescribe devices that are all the way from your head all the way to your foot. So because of that, when we provide you something, even if we're providing you with an insole, we're looking at what your head is doing. We're looking at what your neck is doing. We're looking at what your arms are doing. We make everything that works in alignment with your body. And I think that that's really important when you look at conditions such as EDS, because it is a multifaceted condition and it does affect every single part of your body. So I think that that's really important to establish in terms of orthotists. So what orthotists also do, so we manufacture and prescribe everything from insoles, ankle braces, splinting such as AFOs, DAFOs, knee braces, CAFOs. If anyone's seen a CAFO, do you remember the film Forrest Gump where he's wearing the metal device from his hip all the way down to his foot? So that's a CAFO. Hip orthosis, spinal orthosis, lumbar orthosis, fracture. So we also provide all the spinal bracings for scoliosis, which again can be quite common in terms of hypermobility. We do upper limb, we do neck collars for head drop. We also do helmets for epilepsy and challenging behavior. So again, it's quite a complex career and it's quite a complex varying devices essentially. So again, we're looking from everything from your head to your toe. In terms of podiatry, MSK podiatry look at everything from your foot and ankle. So they're a really great speciality, but they do focus on the foot and ankle. Whereas when we're looking at your foot and ankle, we're essentially looking at everything, as I said, from head to toe. I have a lot of podiatry colleagues, and I work with quite a lot of leading podiatrists within the UK and Europe. And when we discuss EDS, when an EDS patient comes to podiatry, they always tend to refer them over to orthotics, because I said, because it's so multifaceted, and we do need to make sure that everything that we're manufacturing in terms of looking at your biomechanics works in alignment with everything else that's going on. I think one of the big things that tends to happen when EDS patients come in to see me and they've had devices from other departments, they're not necessarily working in line with everything else that we want to be able to achieve. So if somebody was to give you something that's going to control the range of motion in your knee, but it's not then working in alignment with what we're doing in terms of your foot. So it's really important that we get that flexibility and have all of the devices working in conjunction together. So in terms of proprioception is incredibly important when we're looking at gait analysis. And it's also incredibly important when we think about patients who have EDS. So proprioception is a subconscious process. So if you was to close your eyes and hold your arm directly out in front of you, your brain instantly tells you how far your arm is essentially out in front of you without you having to look with your eyes open. So it's a really great process. What we tend to find with people with EDS is that proprioception is quite impaired. A lot of the research indicates that it is quite reduced, a lot in the upper limbs and the lower limbs, and particularly in areas like your knee and your shoulder. So when your proprioception is reduced, what happens is you're not then able to realize when you're moving your body in excessive alignment. And that's the thing with us who have EDS, because we have quite a lot of hypermobile joints, our brain is then not able to tell us when we're going a little bit too far for normal range of motion. So because of that, that really impacts EDS. And that really then impacts thinking about injuries that hypermobile patients then have within their joints. So thinking about your gait. So gait is incredibly important with every single person. So with me, a patient doesn't come to me until the point that there is an issue with their gait. So all the professions that are qualified in gait analysis, we are looking at what is then a compensatory gait. So if you think about a normal gait, you have your swing phase and you have your stance phase. So the stance phase takes about 60%. So stance phase is essentially when your foot is placed on the ground, and then your swing phase is when your leg is off of the ground and swinging through before it goes into initial contact. So that's really, really key at looking at when you're diagnosing a patient. So you're looking to see if all of those phases are in a line. You're also looking to see if the four rockers of gait are in a line as well. When you're looking at gait analysis, you're looking at it from all planes. So you're looking at it from your sagittal plane, your coronal plane, your transverse plane. So it's really important that when a patient comes into your room, you're looking at them in all different planes of motion. The other thing that's really important to have a look at is the patient's range of motion. So with us with EDS, you'll find that our range of motion is a little bit more than we want it to be, but there also might be some muscles and some ligaments, because of multiple damages and strains and dislocations and things like that, where the range of motion has become a little bit more impacted. So it's really important that when a patient comes into your room, you're able to distinguish all of those elements. The other thing that's really important when you think about gait analysis as well is the tibial inclination. So that is, you've got your foot and then you've got your tibia. So it's when your tibia then inclines. So that's really important that we get a good amount of that during the gait processes. And that's another element that we look at when we're doing a gait assessment. The other important thing to think about in terms of gait is when you're doing a heel strike, you then roll into pronation. So pronation is really important to get shock absorption. What you tend to find with patients who have EDS is sometimes they roll into pronation a little bit too much. So they tend to then get a little bit more shock absorption and not enough propulsion in their gait. So essentially, if you're thinking about normal walking, you're going to do heel strike, roll in to get pronation, so that gives you shock absorption, and then you're going to roll out. So you don't lock your joints, but just think of that in that manner so that enables you to think of the next thought process. So you're going to go in, roll out, all of your muscles, your ligaments tighten, and that progresses you forward through into your toes. So that's really important to think about when we go through the next stages of the slides. So in terms of research, and when we think about EDS, there's been so much research into so many different conditions that as soon as a patient walks into my room, I can tell you if they've got Parkinson just by looking at their gait. I can tell you if they've got cerebral palsy just by looking at their gait. With EDS, there has been some research, but it's still not completely inclusive. So a lot of the research, when you think about hypermobility, tells you that they're a pronated foot type, they're a flat foot. That's not necessarily true in EDS. And what you tend to find looking at your own patient basis, I would probably say about 50% are pronators, and then the other 50% are actually supinators. Still to this date, there has been research, but there's no conclusive research as to why we have both of these essential gait patterns. So what I'm going to do today is I'm going to have a look at a hypermobile foot, focusing on pronation, and we'll go through what that essentially looks like, what conditions are then associated with that, and then what is the orthotic treatment. And then we'll go into the supinated foot type, because we do have a lot of patients with EDS who have a supinated foot type. From like myself, for example, so I have a supinated foot type, and that gives you a whole load of other conditions as well. So when we think about gait, as I said, when patients come in to see me, it's at the point of they're in a pattern of compensation. So because your brain is such an amazing device, your brain wants you to be able to take steps, your brain wants you to be able to walk. So that's why gait deviations are generally patterns of compensation. And we are then looking at where those stresses have aligned. So if you think about the human foot, it's an amazing complex structure. You've got your bones, your muscles, your tendons, your ligaments. But in a hypermobile foot, we get a little bit more of increased range of motion. Some people is quite an extreme increased range of motion, and that's when you get your planar valguses. Because we're going through this range of motions in quite extreme cases, it tends to lead to more instability and then an increased risk of injury. So looking at the stress of the biomechanics of a hypermobile foot and ankle can result in quite a lot of different issues. So when a patient comes to see an orthotist, we have quite a few different biomechanical objectives when we're looking at orthotic treatment. So first of all, we're going to do our gait assessment, we're going to do our range of motion, and then we're going to look at identifying tissues that are under increased strain. We're going to then look at what orthosis we can use. Again, as I said, there's such a huge array of orthosis. So when I say orthosis, a lot of people link that with insoles, but that's not the case. Podiatrists call insoles orthosis, whereas an orthosis is actually anything that looks at realigning the body. So we look at applying forces to reduce pathological loading forces to those tissues. We then look at creating rotational equilibrium, and we maximize sagittal plane of motion. So when I talk about a compensation and I talk about looking at what we can do to reduce those pathological forces. So if we just take Morton's neuroma, for example. So Morton's neuroma is a bundle of nerves that are inflamed between your metatarsal heads. So imagine this is your foot. In between each of these lines, you have nerves. So in between these metatarsals, you've got nerves. When your nerves become inflamed, they create a little bundle. So when you think back to your gait, so as I said, you do your heel strike, you roll in, you roll out, you roll forward. When you roll forward, your metatarsal heads squeeze together for that propulsion. When they're pushing together, that then pushes on your nerve bundle. So that's when you start to get a lot of pain and a lot of inflammation, and that nerve bundle tends to grow. So when we think about it from an orthotic point of view, what we want to do is to be able to reduce those stress and that loading. So with the devices that we give a metatarsal bar. And although the neuroma will be here on your metatarsals, we put the neuroma bar behind your metatarsals. So that's really important to think about when you're thinking about orthotic equipment, because we do have patients that come back and say, but this is the part of my body that essentially hurts, but you've gave me something that's further up. And that's because you've got to think about the way that your muscles work, your ligaments work. And it might not be that we want to impact particularly on that joint. We want to take the joint further away to be able to control that area. So again, if you think about Morton's neuroma, we're going to put that bar further back and not on the area, because if we put it on the area of the neuroma, which is going to cause a lot more pain. We want to take it behind the metatarsals so that when we're walking, we continue to keep those spaces and those metatarsals are not going to push together on the neuroma. So it's really important when you think about orthosis that it's not necessarily on the area, it's discovering where that stress is, where that stress has come from, and then what we're going to do to apply new forces to be able to put people into a cognitive pattern. So thinking about pronation, there's two types of pronation. So you have midfoot pronation and you have hindfoot pronation. So it's really important to be able to distinguish between both of them because both of them have different treatments. So when we think about a midfoot pronator, you have your nice arch profile, but the arch of your foot is slightly lower, but the back of your foot, your calcaneus, is still in a neutral position. So if we look at these diagrams here that's on the screen, the one that says neutral, so the back of your calcaneus, which is your heel here, stays neutral, but your arch profile is lower. So when your arch profile is lower, that's what we class you as a midfoot pronator. For a midfoot pronator, the treatment is very different. So as long as there are no other biomechanical issues going on in the forefoot and it's purely a midfoot pronator, you can have a stock insole. So you can still go into custom insoles, but the main part of it is to control the arch. So you want to have something that's got a really nice valgus support. So valgus is just a fancy word essentially for filling that arch profile. So you can be prescribed with devices that may not be custom. They may be off the shelf because we're just looking at controlling the arch profile. When your hind foot is involved, that's a little bit more different. So as you can see from this picture here that says pronation, when the hind foot is involved as well as the midfoot, you go into a valgus position. So when you go into a valgus position, the only way that you're going to be able to correct the whole of the foot is with a device that's got a lot of posting underneath to bring calcaneus back into neutral. So when we look at assessments for this, we do a lot of assessments to essentially have a look to see if your foot is still correctable. And that really then depicts on what sort of insole that we would prescribe you. So if your foot is correctable, we would look at things like lifting up your big toe. By lifting up your big toe, we can have a look to see if your arch profile recreates. So if you have a look at my little skeleton here, as soon as I lift up this big toe, this arch profile, then what that does is that lifts up. If that doesn't quite work, the other different assessments you can do is you can ask the patients to go up onto their toes. So when you ask the patient to go up into a heel raise and you're standing on your tiptoe, what happens is your calcaneus comes back in. When your calcaneus comes back in, we know that there's a lot of correction that we can still get out of the foot. When the foot is correctable, and that's when we'll come in with quite a lot of forces to build you an insole that has different devices, i.e. posting or skyves, to put you back into a neutral position and get you walking into a good alignment. When you're at that point that your foot is not correctable, that's when we have to look at accommodating devices. So when it's not correctable, we would then accommodate your foot into an insole, and that tends to look like a TCI. A TCI stands for total contact insole. So the reason that we do that is because there's no correction within your foot and ankle. So if we was to try and correct, we're just going to put your foot into more compensatory patterns, or we're going to give you more sprains and we're going to give you more inflammation, and we're going to essentially, it's not going to be great for your foot and ankle for everyone down the line. So when we think of orthotic intervention, so as I said, if you're a midfoot pronator, you can just have a device like this insole on the right, which just has this arch profile here. You can even purchase things like this off of Amazon, as long as they are completely neutral at the heel and have an arch profile. They will help any patient who has a midfoot pronation. If you have the hindfoot involvement, then that's when we need to come in, as I said, with something that's a little bit more stronger. So in terms of insoles, you have TCIs, which are total contact insoles. So they are normally made out of things like EVA. And what that does is that gives you a really nice strong base, and we can then add posting or adaptions onto the bottom of them to bring your calcaneus and the rest of your foot structure back into neutral and into a gait alignment that we want you to be in. TCIs are also used for patients when there's no correction. So the reason being is a TCI is a really good way to model the foot essentially with a really nice device that gives you the amount of support so that we can stop further progression, but still hold your foot within a slightly good alignment while accommodating the fact that we can no longer get correction. FFOs are a little bit more different. So an FFO is something that's a lot stronger. So we class that as a functional foot orthosis. So this one on the right-hand side, this insole here, this is a functional foot orthosis. This is actually a custom device and it is a 3D printed device. So one thing about the company that I essentially work for is we have a quite high-tech 3D printing devices within our service. So any of the clinics that you find that is an Opcare clinic, we have the ability to 3D print, not just insoles, but 3D print quite a huge different range of orthoses that essentially some companies don't have. So when we think about a FFO for a patient who has significant correction and we can get them back in a really good alignment. So now we're just thinking about the hind foot and the midfoot. We're going to talk about forefoot a little bit further on in the slides, but I just want you to think about the hind foot and the midfoot at the moment. So when we're looking at what we want to do to correct, so we're going to do medial posting. So my go-to really for a hypermobile patient, again, this depends on how much degree of pronation a patient has. So if we're just talking about a standard patient that would come in, not somebody who's in extreme pronation and extreme valgus, I would tend to do about 4 mil medial posting, and then I would do a 4 degrees skive as well. So a skive, what we do is can everyone see my mouse? Yeah. If you could just put in the chat real quick if you can see my mouse on the screen, and then I
Yes, we
can.
can see it.
Perfect. So in terms of the heel, within the heel, what you do is you do a skive. So if you imagine this is nice and flat, and then we do a skive on the inside of the insole. So what that does is that gives us greater motion to push the calcaneus back into neutral, but it also means that we can put a lot of adaptations within the inside of the insole to reduce the bulkiness on the outside of the insole, because there's no point making this beautiful insole that's going to give you a lot of correction if you can't fit it into a shoe. So what we really try to do is we try to build a lot within the insole itself so that it's more easier to fit within a patient's footwear, because let's face it, it's quite hard in general to get footwear to fit orthosis in. So that's a really good way just to keep the bulkiness down. So that's what we tend to do. We tend to build a lot of it within the heel, and then we want to increase the arch profile as well. So we're going to push that arch and we're going to control everything from the hind foot and the midfoot and then put you back into neutral. Other things that we look at doing as well is if there's a degree of pronation and it's quite severe. So in terms of the other slide where you could see the foot was really leaning over and it was really in quite a significant valgus position, there are devices such as UCBLs. So those are insoles that have quite high medial and lateral lines. So it encloses the foot in just to give a stronger degree of correction. The other devices that we would give as an orthotist is if a patient is in extreme pronation or extreme supination and an insole isn't going to quite be able to control, what we do then is we look at devices like this splint, such as a DAFO. So what a DAFO does is a DAFO looks at controlling medial, which is the inside, and lateral, which is the outside control. So you can see with the lines here, that comes up quite high on the medial side there and then quite high on the lateral side. And what we do is we try to encompass, sort of control the medial and lateral side of the patient's foot to give them as much support and can keep them as neutral alignment as possible while controlling their gait. So thinking a little bit further now into pronation. So when we get to a point that we're not able to correct anymore, and we get to a point where there's a lot of inflammation because the stresses on the structure of the foot have just essentially become too much. What tends to happen is you tend to go into a condition called PTTD. So it's posterior tibial tendon dysfunction. So essentially it's a condition that affects the tibialis posterior tendon. So this tendon is your big tendon that runs on the outside of your foot and then directly into your arch profile. So it's completely responsible for holding your arch profile. When you have such a high degree of pronation and the inflammation has just become too great, that muscle just basically says, hey, I can't do this anymore. And it becomes so inflamed and is not able to function as much as we would want it to. So when it gets to this stage, you go into PTTD. So there is 4 stages. So stage 1 is a lot of inflammation and swelling. So you'll know if you have this condition because you can see my little model. So your tib post runs down here and then inserts here. So around your navicular, you'll get a lot of swelling around that point within your muscles. And you can actually see it and you'll be able to palpate it as well on your foot and ankle. So you'll get a lot of swelling around the area. There's a lot of pain. And you'll find it quite hard in terms of when you're walking, you'll find that your arch profile is a little bit lower. In stage 2, the tendon begins to elongate and weaken, leading to a noticeable flattening of the arch. I'm just going to move our chat bar here so I can see, and the foot may start to roll inwards. So stage 3 is when the arch completely collapses and the foot becomes more rigid and pain and deformity is more pronounced, and the condition may start to affect the alignment of the entire lower limb. So when I mean affect the alignment of the entire lower limb, so if you look at my skeleton here, so if we're thinking about the pronation and the rolling in, it's basically your whole ankle starts to go in this quite extreme valgus position. And then stage 4 is when the condition is progressive and it involves the ankle joint as well, leading to arthritis and significant disability. So when we are thinking about orthotic intervention for people who has PTT dysfunction, there's quite a few different stages depending on what stage you're in. One thing that we tend to look at first of all is insoles. We want to be able to post underneath that area. So again, it's going to be quite aggressive medial posting, quite aggressive skies. And the idea behind that is by putting patient's foot into alignment, we're taking that pressure off of that muscle and allowing that muscle to relax slightly, and hopefully the inflammation starts to go down. If that doesn't quite work, then there are other devices that we look at, such as splinting, which does the same thing. And the whole idea behind this is to take stress off of that tib post muscle. It's really important because the last thing you want to do is you don't want that to progress to the point when we class it as plastic. So when we class it as plastic, we mean it's completely rigid and there's not much treatment that we can give you. From an orthotic point of view, that would be when you see orthopedics and we think about things such as surgery. But from an orthotic point of view, when it becomes a plastic range, that's not when we're able to essentially be able to help with tib post dysfunction. So, but we look at things like splinting that again is going to push the patient into a neutral alignment. We look at footwear adaptation. So if we're not getting that full correction from doing the insole, we can look at putting medial posting on the bottom of the patient's own shoe. And if that doesn't quite work, then we can look at things like orthopedic footwear to really bring that patient's foot round into that neutral position. So now thinking about the forefoot. So if you imagine now we have a patient's foot that is midfoot and hindfoot in pronation. So if we go back to that original module I was saying when we walk, so you've got your heel strike, you roll in, you roll out, you progress forward. When you have a pronated foot, you're doing a heel strike and you're rolling in. You're not getting any of that outside movement, so you're getting too much shock absorption. So you're doing heel strike in. When you're in and you start to walk, you have no choice but to start impacting this big toe. And over time, this big toe starts to get a lot of wear and tear around the joints. And that's where it starts to go into conditions such as functional hallux limitus. So functional hallux limitus, so hallux is just a fancy medical word for saying big toe. Limitus, it means it's a limited capacity, but it's still functional. So essentially, it's a condition where the big toe has limited movement during walking, despite having normal range of motion when the foot is non-weight bearing. So the way that we would test for this is when the patient is not weight bearing, so you can lift their foot up and you lift their big toe, essentially, you can see we've got a movement at this joint here. When the patient is at weight bearing, and we try to lift the toe, we're only getting movement from this point. We're not getting movement from this point. So you can see that it's still functional because it's able to move, but it's at a limited capacity and it's not doing the job that we want it to do. So functional health limiters can be caused by factors such as joint hypermobility, muscle imbalances, or structural abnormalities of the foot. So again, just thinking about it at the moment in terms of hypermobility and pronation. So again, as you're walking, you're locking that big toe joint. So over time, it has no choice but to start to get wear and tear. It's also associated with pes planus, flat foots, and PTTD. So what happens is you increase the soft tissue stresses around that tendon and the medial band of the fascia. So as you can see, as we're going through, we're linking in all the conditions and how they essentially affect from hypermobility. So you can see that this here stems from the medial band of the plantar fascia, which is why that essentially links into plantar fasciitis as we go along in terms of the slides. So as functional health limiters progresses, and you get wear and tear within the joints, what tends to happen is over time, because you're locking this joint, this toe has got no choice but to start to go into a valgus position. And that's when you start to get conditions such as bunions. So with bunions, there are four stages. So stage one is when the big toe begins to deviate towards the other toes and a small bump forms on the outside of the hallux. Stage two is the deviation becomes more pronounced and the bump of the side of the toe starts to become quite enlarged. Stage three, the toe continues to deviate. And stage four is when the deformity becomes so severe that the toes may overlap. So, and you can see that from my demonstration here. So you can see stage one, you've just got a quite slight little bump that will appear on the side of your foot, on the side of the hallux, and then you can see as it progresses. When you're at stage three and stage four, that's normally when they start to look at doing surgery. And when you are at stage three and stage four, you see an orthotist, the main things that we start to look at doing at that point is looking at orthopedic footwear. Just because at this point you're not going to be able to get into normal high street shoes and it can be quite impinging and quite painful on a patient's foot. So when we think about orthotic intervention for both of these conditions, so let's think about functional health limiters. So with functional health limiters, what we want to do is we want to make it functional again. So as I said, when a patient is non-weight bearing, you're able to move that hallux, that big toe joint. When the patient is weight bearing, that's when it becomes a little bit more locked and a little bit less functional and a little bit more at a limited capacity. So what we look at doing at that point is what we do is a reverse Morton's. So what a reverse Morton's is, so see my mouse here. So we've got your nice arch profile here. So your hallux will be situated in this point on the insole. What we do is we drop the hallux down. So you can do things like that, like a first ray cutout, which is essentially comes all the way back here on your foot, and you cut that whole of that area out and you allow that toe to be lower down than your second to your fifth toe. And you can do what we class as a reverse Morton's. So what reverse Morton's is a pad that essentially comes underneath the metatarsal heads here on the second to the fifth and extends to the end of the insole. What that does is that raises up the other toes, leaves that big toe alone, allows all of the forces to essentially go over the other side of the foot to allow that toe to become more functional again within the insole. So if we're building on pronated insole, we're going to have your heel foot posting, your skives. You may have a flange as well, which is essentially building up the insole a little bit higher, just so that we can control the foot process. And then thinking about the forefoot, you're probably going to do a sink and plug at the first met head, or you're going to lower the first ray and you're going to look at reverse Morton's. Now, when we're looking at bunions, what tends to happen, because there's a lot of wear and tear in that joint, you don't want that joint to be free now. You want to stop that wear and tear. So you really want to stop that movement within that joint. So you do the opposite. So with the opposite, we call it a Morton's extension. So basically we put an extension underneath the whole of the hallux. So what that does is that reduces the movement so we can stop that bone on bone. Again, with anything that starts to go into arthritis and wear and tear within the joints, with devices that, whether it's an orthotist or it's a podiatrist, It's not something that we can stop because it's happened, but with certain adaptations, we can start to slow down the progression of it. But it's not something that can be stopped because it has started to happen. And when you get to the point of grade 3 and 4, as I showed you in the previous slide, that's when we start to look at orthopedic footwear, and just giving that really nice wide toe box and deep toe box so that we can stop impinging on those toes. So that leads us into plantar fasciitis. So as you can see, you've got the functional hans limitus that connects to the medial band here. So you can see this section here where it's connecting to the medial band from the hallux. So everything is quite interlinked. So again, thinking about hypermobility and the stresses, essentially plantar fasciitis is quite a lot of stress within that joint, and it's more prominent for patients who are pronated because you're putting a lot of stress within that area. So if we just think about what the plantar fasciitis is in general, is a thick band of connective tissue located on the bottom of your foot. It's really crucial at keeping your foot structure along with your tib post, and it originates from the heel bone. So it originates all the way back here and extends all the way into the forefoot. So windlass mechanism. Windlass is really important to understand when we think about the plantar fascia. So what the windlass does is it's how the plantar fascia supports the arch. So when the toes are dorsiflex, so as you can see from my diagram, when the toes are dorsiflex, which means they're pointing up in the air, the plantar fascia is pulled really tight. Let me just move us out of the way, which elevates the arch and stabilizes the foot. When this mechanism is really, really essential for propulsion and distribution across the joints. So you can see when this area then becomes inflamed and has plantar fasciitis and degeneration, that's when your windlass mechanism isn't quite functional. And that's when you start to get a lot of issues within your gait, because your windlass mechanism is so essential to your gait analysis and the function of your foot and ankle. So in terms of plantar fasciitis, fasciitis is my bugbear. The reason being is itis basically means inflammation. And although there is inflammation within plantar fasciitis, it's not the true cause of it. So when you look at research and imaging, they show that plantar fasciitis involves a lot of degeneration. So essentially, fasciitis is the wrong terminology, and a lot of people now are changing that terminology in terms of when they diagnose this condition. So a lot of the times people tend to refer to it as like plantar fasciitis, plantar fasciitis. So then that just essentially means degeneration. So what tends to happen is the collagen breaks down. Obviously, us with EDS, our collagen is not the best as it is, and you tend to get micro tears and thickening of the fascia, and it really deorganizes that tissue structure. So that's when you start to get a lot of breakdown within it. So with plantar fasciitis, before I go on to the next subject, what I would say is it's really important that you have a really strong insole. The reason being is you want to be able to stretch that plantar fascia. The other thing that's important with plantar fasciitis as well is things like plantar fasciitis splints. So they're really good to wear at night. And what they essentially do is they hold the foot at a 90-degree angle and just really stretch that plantar fascia. If you ever have an orthotist that prescribes you a plantar fasciitis splint, it's really important that you position yourself sleeping at night with your leg completely straight at a 90-degree angle. As soon as you turn to the side and bend your knees, you actually take the stretch off of your plantar fascia, so it stops the device from working. So it's really important that you keep your leg at a 90-degree angle. So it's really important in terms of stretching out the fascia. When you have inflammation, because there's always a degree of inflammation, other things that you can do as well is fill a water bottle, put the water bottle in the freezer, let it freeze, and then once that water bottle is frozen, just rub it along the arch of your foot. So that's really good at help breaking down any inflammation that you've got. Insoles are really important. What we tend to do is we tend to do a really nice strong arch profile so that we're stretching that plantar fascia, but then we also do our sink and plugs that can potentially be around the heel area so that we get in that soft and that comfort and that shock absorption within that area. So thinking about a supinated foot now. So as I said to you, the research we both know looking at patients' feet, we get a good 50% of pronators and a good 50% of EDS being supinators. So I think it's really important that we look at that essentially. So a supinated foot, you can see, tends to roll on the outside. So with a supinated foot, the characteristics tend to be a pes cavus foot, which essentially means quite a high arch. You tend to have clawed toes as well, and you have forefoot equinus. So what I mean about forefoot equinus is if you were to lift your foot up and your heel is here, but your toes are lower down. So if I bend this foot down, so you can see my heel is up here, but the toes are lower. That's what we would class as a forefoot equinus. So you tend to find patients that are supinated tend to take a lot of stress along their forefoot instead of taking the main weight load through the hind foot where it needs to be. You'll also find, because their walking pattern tends to be heel strike straight on the outside, they're not getting any pronation, which means they're not getting any shock absorption. So what you tend to find with patients that are supinated, you tend to find that they are more prone to strains, sprains, and fractures because they're not getting any shock absorption in the gait. So what I mean by that, if you imagine every single step that you're taking, essentially, so if you imagine every step, that vibration is going all the way up your body because you're not getting any shock absorption. And I always have patients that come in with EDS and say, like, my shoulders hurt, my ankles hurt. And a lot of the time, when you bring them back into neutral and you give them that shock absorption, they tend to find that their shoulders stop hurting or other parts of their body stop hurting. And that's just because of that vibration that's essentially going all the way up the body. So let's go back a slide. So before we go into different pathologies essentially affect the tendons around the foot, let's still think about supinators. So what we want to do when we want to prescribe a device that brings a supinator back into a neutral position. So let's go back a slide. So if we think about this foot here and we want to bring them back into neutral, what do we need to do? We need to do the opposite of what we would want to do in a pronator. So we're going to do lateral posting. So lateral means the outside, and we're going to bring them back into neutral. What we also want to do is we want, instead of increasing the arch profile that we would want to do in a pronator, we want to lower the arch profile so we can bring them across and give them a little bit more shock absorption. We then want to have a look at if there is any forefoot equinus. If there's forefoot equinus, again, your heel is higher, your forefoot is lower than your heel. So you want to bring them back into alignment and just make sure we're taking all of that weight distribution where we need to be taking it. So with supinators, a lot of the time they can go into functional foot orthosis. Very rarely have I ever had to put them into a TCI. A lot of the time, a lot of the patients at supinators that have EDS are quite correctable. Very rare have I seen an EDS patient that is a supinator that is just gone too past the point of correction. I think I've probably seen a couple in over 10 years. Generally, most supinators that are EDS patients, I can get back into a really nice neutral position. So thinking about some ankle conditions now. So thinking about supination again. So you have a really nice long muscle and ligament that runs down the outside of your foot, which is your peroneals. So what you'll tend to find with supinators is that a lot of them tend to get peroneal tendinopathy, which is inflammation down the lateral side of the foot. The reason that they tend to get this is because there's no shock absorption. So a lot of patients who are supinators, no shock absorption. So you tend to find those patients are more likely to trip, stumble, sprains, strains, fractures, a lot of impingement within this ligament and this muscle. So you tend to find patients who have peroneal tendinopathy have a lot of trauma and a lot of repetitive sprain injuries that essentially stem a lot of the time from supination. So with the symptoms, you're going to get pain on the outer ankle, so most common behind the lateral malleolar. So the malleoli is, so it's going to be behind there. You can have tenderness to touch, you're going to have pain during activity, and you're going to have feeling of ankle instability or giving away, and you're going to have quite a lot of trouble with balance. You might feel a catching or a snapping sensation on the out of the ankle when you're trying to walk as well. And you might find a lot of stiffness or pain in the morning. That tends to be worse after resting. So what you tend to find with this condition, that after a period of resting, you tend to find quite stiff and quite pain. Whereas once you've gone throughout your day, you've done a little bit more movement, you tend to find that it improves very, very slightly, but you still got that pain there, but you find that it's a little less stiff than it was after a period of rest. So treatment from an orthotic point of view, we would look at doing insoles. So very, very similar to PCCD and any condition. When you look at orthosis, you're going to look at what that stress area is, and you're going to look at essentially how I can reduce that stress. So because all of this is on the lateral side of the foot, it's very simple. You're going to put a lateral post in and you're going to push them back into that neutral position. So you're going to let that tendon and that muscle just to relax. If it's got quite extreme and you need to take a little bit more pressure off of it, then we would look at things such as bracing that really brings that patient's foot back into a neutral alignment and really just offloads that area. One of the slides that I've done further down, I've put some pictures of bracing that I find most useful in EDS patients, not just because of the conditions associated with these, but mostly because of EDS patients and thinking again about the body as a whole and thinking about hand dexterity and issues with donning and doffing devices. So I put this slide together purely so that you can see devices that I find that patients with EDS get along with the most, because it's quite easy of being able to put them on and also help with any hand dexterity issues. So in terms of spring ligament tears, so this now again is thinking about pronation. So with your spring ligament, it's a thick and wide band of cartilage connective tissue positioned on the underside of the foot. So it's across the calcaneus and navicular, so you can see here from the diagram. The function of this is to provide stability to the medial arch of the foot. So it's along that tib post, as you call, we've already spoke about tib post dysfunction. So it just runs alongside that. So you tend to get this with trauma, prolonged increased soft tissue stress, excessive pronation, and you tend to get pain along that plantar posterior arch. And you may also get pain along the other sides of your foot, because if you think about your foot in general, you're going to be compensating. So your symptoms are pain on the inside of the foot and ankle, swelling and tenderness near the arch, flattening of the arch profile over time, difficulty standing or walking, especially on uneven surfaces. So if you think this ligament is near the tib post and both of them are responsible for controlling that arch profile, if you're on uneven surfaces, your foot and your muscles are not going to be able to compensate to be able to control the uneven elements. So in terms of treatment, you're going to look at immobilization. So again, depending on severity, surgery, depending on severity, physical therapy, and then orthotics. So again, thinking anything that is inflammation on the inside, you're going to want to put that wedging on the inside to bring that patient into neutral alignment to allow those stresses off of those muscles and those tendons. So with all of these conditions, and when you're thinking about insoles, essentially you just need to figure out where the stress is, if it's on the inside, the outside, or the back. And then that's essentially where you're going to post to be able to let the inflammation go down. There's lots of other different devices as well that we would put into the insoles. But if you just have that into your mind, if something's on the inside, we're going to post on the inside. If something's on the outside, we're going to post on the outside. If something is in the hind foot, we might do a heel raise to offload essentially. Again, I'm making it sound quite simple. There's a lot of other elements that need to go into building of the insoles, but it's a good understanding to be able to understand essentially that what part of your foot is affected, what we're going to try to be correcting. So acute ankle sprains. So causes are trauma, hypermobility, and perineal weakness. So in terms of sprains, there are 3 different grades. So grade 1 is stretch of the ligament. And so you tend to get minor swelling, but no joint instability. Grade 2 involves partial tearing, which is minor to moderate swelling and some instability of the affected ankle. And grade 3 involves complete rupture of the ligament, so significant swelling, tenderness. So with sprains, the symptoms are sudden pain. So often on the outside of the ankle, the pain may worsen with weight bearing or with movement. You get a lot of swelling, a lot of bruising, instability or weakness, and limited ROM. So ROM is range of motion. So you'll tend to find that when you've got a lot of swelling or inflammation in that area, your range of motion becomes quite limited. So In terms of thinking about bracing for sprains, these are the bracings that I would use, but it's also the braces I would use for the other ankle conditions. They are also useful for patients who are supinators and patients who are pronators. So this first device here on the left is by a company called Firefly. So you can actually get this device. So this is just a standard stock version. But what is great about this company and this device is you can do a custom version. So a custom version involves taking a plaster cast of a patient's foot. But what is great about it is although this space here is flat because it's a stock version, on the custom version, the space is actually built into an insole. So you essentially get two for the price of one. And it just makes it a little bit easier to essentially fit into your shoe. This one is called Air Sport, and it is by a company called DJO. So what is great about this is you can see here, it pulls from the outside, so that's going to give you a little bit more control and pull you into a neutral position. So both of this one and this one on the right is very similar. The difference between the middle one is not that you can see it, but on the back, can you see this strap here and this strap here? So the back is actually open. So if you really struggle with fluctuation and your foot fluctuates quite a lot, whether it's swelling or edema, this is quite a good brace because it's open at the back and you can just Velcro it shut depending on what your fluctuation is. This one here on the right-hand side is my favorite brace. So this is called a Malio Dynastab by 2M. What is great about this brace is it's absolutely brilliant for poor hand dexterity, which I know us with EDS tend to have a lot of poor hand dexterity. So what you do is you essentially put it up like a sock. You have this boa device here, which you click in and then you just twist. And then to undo it, you just basically pull and the whole device undoes. So you haven't got to worry about trying to do Velcro or things such as laces. Just a nice quick twist of the dial and the whole device connects. You then have these two elastic parts here. So what you do is you pull one across and then one across the other. So if you tend to find that you're a pronator, you would tend to pull the medial one, so the inside one a little bit stronger to pull you in neutral position. If you've got issues on the outside, you would tend to pull the outside one a little bit tighter so that you can control whether you're controlling medial or lateral. So these are my go-to. This one here on the right-hand side is my initial go-to, and then I tend to go to these other ones afterwards. But this is the one that I find really useful for any foot and ankle conditions, and I tend to find patients with EDS tend to get on with this the best. And then I would start to go into the others. But in terms of stock devices, so one thing I would say about orthotists, a good 80% of our devices are always custom. However, if there are cases that we need to use stock, then there are a million different stock devices out there, which can be quite confusing if you are non-clinical and trying to find the ones that are best for you. So for me, just trying to narrow it down for you guys, these are the ones that I would tend to use the most in terms of my EDS patients. So footwear. I can't be an orthotist and come on here without start talking about the importance of footwear. So really important when you think about types of devices that you want to wear. So I'm going to talk footwear through for patients who are not wearing insoles and what you need to look out for. And then I'm going to talk about footwear for patients who are wearing orthotic devices and essentially what you need to look for. So if you are a pronator or a supinator, you can go into different shops such as Hoka's or New Balance or Asics, and they will be able to give you a trainer essentially that has an inbuilt, so they call it the wrong terminology, and it is my biggest bugbear. They call it over pronator and under pronator, whereas it should be pronator or supinator. But you can get a really nice trainer that is essentially built to control pronation or supination. You need to make sure that the shoe is really sturdy and it's not flexible. So when I mean sturdy and not flexible, what you want to do is you want to hold any of your shoes, doesn't matter if it's a trainer or a normal shoe, you want to hold the heel counter from behind and you want to hold the toes and you want to bend. If that shoe completely bends in half, it's too flexible. You only want to have a bend at the toes and that is it. That's really important as well for having a device such as an insole, because if you have a really nice insole that's doing the trick for your patient and then the patient comes in and they're wearing a shoe that's too flexible, you've just stopped the insole from working. So that patient is not going to get any benefit from it. So it's really important that you have a really sturdy shoe. Heel height's really important as well. So you don't want to be walking around in something that's 2 centimeter heels, because if you look at your foot, you're going to put all of that pressure into your metatarsals, and then you're going to be more prone to some of the conditions and the forefoot conditions that we spoke about today. So it's really important that you have a really nice heel height. So you really don't want to be anything more than about this. Anything further than that, you're just going to push all the pressure into the forefoot. Donning and doffing is really important. So you really want a shoe that is not a slip-on shoe. You really want something that is laces or Velcro. The reason being, if you're sliding up and down that shoe, then you're not getting the full support. That's also really important when you think about insoles. So if we go all through these again and we think about a patient who's been given an orthosis, so neutral heel. So if I've given you an insole and I've brought you to neutral, the last thing that we want you to do is to go in a trainer shop or wear a shoe that's got an arch profile or is made for a supinator or pronator. The reason being is I've just made you this really nice insole that's going to do the job. So if I've made you an insole that corrects you, and then you walk into the department and you're wearing a shoe that's for an anti-pronator and it's pushing here, I'm already pushing there to bring you neutral. You're now going to push you too far into supination. So you're going to have the complete opposite effect of what we're trying to achieve. So if you are a patient that wears insoles or any type of orthotic device, you want to be in a neutral heel shoe. What's really great about a lot of shops these days is they now do specify if they're neutral heels or not. If they don't, the way to look at that essentially is to put your hand within the arch profile. If you feel that there's an arch profile, steer clear. You want the arch profile to be nice and flat. The other thing to look at is the back of the heel, the trainer. So if you look at the back of the heel directly and you can see the inside of the train is just very slightly higher than the other side, then you can see it's built for an anti-pronator and you want to steer clear if you are wearing insoles or an orthotic. So really important that you have the neutral heel. Flexible, not sturdy, as we've already said. If it's too flexible, you're going to stop the orthosis from working. So there's no point wearing the orthosis if you're going to wear something that's too flexible. Heel height, again, is the same as if you're not wearing orthosis. You don't want a significant heel height because you're just going to put all of that pressure in the forefoot. 99% of the patients that come in to see us is not just midfoot and hindfoot. There's always an element of forefoot deformity or a forefoot compensation. So there's always elements of the insole that's controlling that. So that's why you really don't want any high heel height, because you're just going to stop the impact of those insoles on the forefoot. Donning and doffing. So again, as I said, really important that it's not a slip-on shoe, because if we've made you an insole and we want to hold certain parts of your body where that insole is, if you're sliding up and down in the shoe, then that insole is not going to situate where it needs to be. So you're not going to get the full force of these insoles and you're not going to get the full effect. So it's really important that you look at all of those elements within footwear. The other thing that I'm going to go into as well, although it's not on the slides, is when you are given an insole, it's really, really important that you break in that insole or any orthosis. So it's really important that when you're given something, you only wear it the first time between 30 minutes to an hour. The reason being is you've been walking in these compensatory patterns for such a long, significant time that it's going to take your body a while to get used to it. So it's really important that you break everything in from an orthotic perspective, i.e. everything that we give you for a short period of time, and break that in slowly. So you're going to want to wear something the first day up to an hour, take it off, the next day 2 hours, the next day 3 hours, the next day 4, the next day 5. Once you get to 8 hours a day, you're going to wear it all the time. It's also really important that every time you take the device off, even if it's an insole, you check your skin. So if you find any redness on your skin and that disappears within 20 minutes, that's completely normal, because we're changing the stress processes on your foot and we're changing the compensatory pattern. So because we're using pressures to get you into a neutral position, if you have redness that lasts 20 minutes and then disappears, that's completely normal. But if you have something that has redness and it lasts over a 20-minute period, then that's when it means there's too much forces in the orthosis. And that's when you need to stop wearing them and you need to contact your orthotist and you need to go back into review to see why the forces are a little bit harsher than we would want them to be. And that's it. I hope that's been really helpful. I hope I've managed to go through it into enough detail, because I was really worried that I was either going to do too much detail or too less detail. So I hope you enjoyed the slides. Thank you.
Hi, Nicci. That was really, really informative and useful. And I'm watching the chat and everybody's saying, oh my goodness, basically, where have you been all their lives? We've got quite a few questions, as I'm sure you can imagine. So I've tried to kind of put them into sort of groups together. Summer shoes, very hard to wear summer shoes with insoles and that kind of thing. Any advice with that?
So, although it's not medical advice, I do have patients that wear gladiator sandals. So, as long as they're closed in at the back and you've got strapping over the front of your foot, you tend to be able to fit insoles in them. So, although it's not technically the correct way of wearing them, we all understand that in the summer months it gets too hot and sweaty and you still want to be as stable as possible. So, I would always recommend gladiator sandals at that point.
Thank you. When you talk about correction, are you meaning that it will change the foot and ankle over time and become redundant, or is it correction only when using the orthotic?
So depending on the condition, so let's just say pronation, for example. So because when we're correcting with an insole, your foot is only going to be corrected while you're in the insole. So what we always recommend with every single orthosis is when you wake up in the morning, you wear the insole, even if you put it in slippers, and then you take it off when you go back to bed. The reason being is if we think about conditions that have high inflammation, if you are only being corrected while you're in the insole and you come home from work and take the insole off, your foot's going to say, hey, what's going on here? I was corrected, I was relaxed, I was allowing myself to heal, and then all of a sudden I'm back into that stress process. So it's really important that with insoles you wear it for a huge percentage of the day to be able to get the best effects. But again, because a lot of stresses tend to become from muscle imbalances like we have with EDS, orthoses are only going to work while you're in them. It's never going to have the power to essentially stop that deformity or that compensation. That would only work if you're working in conjunction with a physiotherapist. So you're looking at building up those muscles and those strengths. Otherwise, your insole is just going to correct you while you're in it throughout the day.
Thank you. And that sort of answers my next question. But one of the bits it was in the next question was, how long are they good for? So if somebody's just wearing them to walk around the house or go to work and they're not getting a lot, but some people might be on trail walks and that kind of thing, how often should you replace them?
So if it depends on the type of insole you've been prescribed. So if you have a TCI, total contact insole, they tend to be made out of EVA bases. So those insoles, they tend to compress. So what we say an NHS entitlement is to replace an EVA insole once per year. The reason that we say replace it once per year is because it condenses down and then you need to renew it. So for an EVA insole, we would say, which is a TCI, we would say one per year. A lot of NHS trusts are really good. They tend to have one per year for 3 years as an NHS entitlement without you having to go back to see the without seeing the orthotist, so orthosis then, orthotist. Because what tends to happen is your foot doesn't change enough to have a new mold until the end of that 3-year period. So when you think about an NHS entitlement, you tend to get an insole per year for 3 years, and then they tend to close the referral, and then that's when they say re-refer to take new molds. If it's an FFO, which is a functional foot orthosis, that's made with a harder base material. So they can be made out of polypropylene, i.e. plastic, or 3D printed base. Those bases can last you a good 5-6 years until your foot essentially has changed. The only thing that tends to be renewed on that is the mid layer or the top layer, which tends to be made out of the spongy material to give you shock absorption. So your actual base is probably not going to need to change for a good 5 years, but your actual middle base, you could always drop that into your Orthotist and ask them to renew them just so you've got that refreshing, that absorption layer. So you could do that yearly.
Lovely. Shockwave therapy for plantar, I can't even say it. Do you know how effective that is? Do you know anything about it? What would you recommend?
So in terms of shock therapy, what I would say, it is quite effective. I would say that I'm probably not the best person to ask just because it's not in my remit. So it's more patients we tend to see after they've had it. It's not something that I am qualified in. But from my experience, it is quite beneficial to patients, but you're probably better off asking a consultant that deals with that to know the ins and outs.
Lovely. Barefoot shoes, good option for a possible, for trying to correct. What are your thoughts on barefoot shoes?
So it really depends on the patient. It really depends on the degree of pronation, the degree of supination. So it really depends. So some people they're brilliant for, other people they're not great for. So what I would always say is go see your orthotist, go let them examine your feet, let them see what degree your pronation is, what degree your supination is, if you've got forefoot issues, hind foot issues, and then they'll let them be able to prescribe them for you or to judge them for you effectively. So it's really hard to say. But I would definitely say patient group that I see within EDS, they're not grateful. Just because you normally need a little bit more extra support than what they can essentially provide you.
Lots of questions around self-advocating. So, you know, if our members are going to see an orthotist, what questions could they ask for the orthotist? But also, how? Sorry, it's a double question. How do they get the GP to make the referral? What should they be saying to the GP as well?
So with different trusts, it's really trust dependent. So some orthotics departments within the trust. So I'll give you a double answer to kind of make it a little more sense with orthotics. So with orthotics, historically, orthotists have always been contracted into the NHS. The reason being is back in I think it's the 1940s, 1950s, they made most orthotic departments be third-party contracts that are contracted with the NHS. The reason being is because otherwise they would have to build factories on site of every NHS hospital, employ technicians, and be able to manufacture all the devices that we make. So essentially, I say a good 80% of orthotic departments within the NHS are third-party companies. And then the ones that are NHS-based, they will still have a third-party company that will manufacture their devices. You've got very few hospitals now that manufacture their own. For example, in terms of London, there's only Stanmore and Charing Cross and Roehampton that do some of their manufacturing. The rest generally tend to be third-party companies contracted in. Even with those that I've said, Charing Cross is a third-party company. It's not a managed service by NHS, and Roehampton is also a third-party company. So it's really about looking at what trust you're going into. Is also looking at whether it's a tertiary trust or if a GP can refer in. So some orthotic departments will accept GP referrals. Some orthotic departments, because it's a tertiary trust, they will only accept referrals from a consultant. So if we look at UCLH, so I manage the orthotics department at UCLH. That department only accepts referrals from a consultant within the trust. It does not accept GP referrals. Whereas I also manage West Middlesex University Hospital that accepts GP referrals as well as consultant referrals. So it's really important that you have a look at the orthotic department. You can always contact the orthotic department and then they'll be able to guide you of what way you can be referred into the trusts. If it's via GP, I would definitely recommend that you ask the GP for an orthotic assessment and don't specify insoles because that gives the orthotist leeway to be able to look at the whole of your body. Because if the referral is through GP and it comes out of GP's budget, if they specify just a knee brace, that orthotist is only going to be able to, even though they'll look at you as a whole, they're only going to be able to prescribe you a knee brace. So it's really important that if you do your GP referral, ask them for an orthotic assessment. So that gives leeway for the orthotist to be able to do what they need to do. If it's via a consultant, we normally work hand in hand with different consultants. So they'll tend to know what to write on the referral to get you into us.
That's really interesting and useful. Thank you. Lots of questions around other body parts. So backs, necks, shoulders, all sorts saying, can that be is that something that an orthotist can help with?
Yeah. So when we, as I said at the beginning, with orthotists, we do everything from helmets, neck collars, back collars. So what you tend to find is all orthosis comes from orthotics. Although you have a physiotherapist that can provide a knee brace, they get that knee brace from the orthotist. So their referral comes to us for us to be able to order in the product or advise them what it needs to be. So you'll tend to find that you may be given devices from other disciplinaries such as physio, whether that's an ankle brace or a knee brace, but they always get it from us. And we do a lot of training with different physiotherapists, even podiatrists. So generally, most orthoses are from us within the trust.
Again, lots of questions about this. How do they get referred to a foot orthotist? Do you do NHS referrals? And if you do, how do we get referred to see you? And if you don't and you do private, again, how do you get referred to see you?
So private, I don't do at the moment just because I am incredibly busy. So I manage all of our orthotic contracts for the whole of London and Kent. So I don't do private at the moment, but I do NHS still. So I practice still 1 day a week on a Monday. And then the rest of the days I manage all the other services and look at service improvements. But my Monday, I practice out of West Middlesex University Hospital. And you can refer into there from all over the country. It is not just borough. You can refer directly in, and you can ask your GP to do that. And the email address that the GP would refer into is westmid.admob@nhs.net.
Say that again. I'm going to put it in the chat.
So Westmid, WESTMID dot ADMOP@nhs.net. And that refers you direct into West Middlesex. And if you put it for my attention, then that will come to myself to triage. So although it's myself and I manage the Orthotist, if you put it for my attention, it will come to me to triage.
Wow, thank you. I've popped that in the chat for everyone as well. And the braces you spoke about in the presentation, do you have links to those, or is there somewhere where they can look at those braces?
So what I can do is I had links set up the last time I did a webinar for you guys, but they're probably finished since then. But it actually gave you a discount on them from the companies. And I don't get any money back or anything like that. It was literally set up purely for EDS patients. So I can ask them if those links are still active. And then if they are, then Nicci, I can send you an email with those in.
Fantastic. That would be really great. Thank you, Nicci. And a few questions. I mean, we're talking a lot about England. What about if you live in Scotland? Do you know anything about Scotland? Is it a similar?
It's a little bit different in terms of health. We do have some clinics that are higher up north, but I'll be very honest with you, that's something I'm probably going to have to take away and have a look at. Because in terms of the company that I work for, although we do clinics the whole of UK and Ireland and Holland, in terms of Scotland, that's still a different area for us. So I'll take that away, and then what I'll do is I'll send you an email, Nicci, and then I'll let you know how they can refer in. So I've just seen that question in the chat as well.
Thank you. And if people are trying to chase referrals, you know, what sort of length of time are we looking at for referrals at the moment? Generally, I know you can't speak to all of them.
So it really depends on the clinic, and it really depends how our service is. So if we're looking at West Middlesex Hospital, that is a managed service. So that means we manage absolutely everything within that service. So our waiting list to see me is 2 weeks. So we cleared the waiting list and it is 2 weeks. If it is a service such as UCLH, because I can see that in the chat, that service is not a managed service. So what we do is we come in and we provide an Orthotist. That service, because of the type of clinic it is, the waiting list for that service is about 8 months.
Okay, thank you. I'm just conscious of time, so there's just a couple more really. KT tape, reducing ankle pain. Any thoughts on that, using that KT tape?
So it's not something that I practice. I do find it helpful, though. I find it helpful for myself, but it's really important that you know how to use it and to make sure you're running it across the right muscle group that you want to try to impact. So I would always say, although it's great, just get a medical professional just to check that the way you're essentially putting them on.
Lovely, thank you. And then last question, slippers, being at home, walking around, you can just put your insoles, presumably you need a closed slipper.
Yeah. Closed slipper, make sure it's not too flexible. And just make sure you haven't got the arch profile if you've got insoles, because you do still have like hotter slippers and things like that that have quite a high arch profile. So just make sure they're nice and flat. And also make sure that you remove your shoe's normal insole when you put our insole in, just because it gives you that nice added depth.
Okay.
The other shoes that I would also say in terms of footwear advice, if you are a patient that wears splints like Dathos and things like that, there is a company called Billy Boots that you can just purchase yourself. They're online. They're absolutely brilliant because they've got zips that go essentially all around the forefoot of the shoe, and they're absolutely brilliant to be able to fit any orthosis in as well.
Brilliant, thank you. That's great. Thank you so much, Nicci, for your time today, and thank you everyone for joining us. Really, really, really interesting. Thank you. And I know that everybody's sort of in the chat saying they've got a lot out of it, all the way along. People saying, "Gosh, you know, that's me." You know, I understand that. So thank you so much for giving us your time. We really appreciate it. And thank you, everybody. And enjoy the rest of the day. Hopefully, it's sunny where you are. The recording will be ready on Monday, so please do email for the recording. So I can see you're frantically trying to write everything down. Don't worry, you can get a copy of the recording. Thank you so much, everyone. Take care.